Good afternoon and welcome everybody to today's Health and Wellbeing Board here in Kirklees on Thursday the 16th of July. Could I ask board members to keep their video on, other people in attendance or who are going to speak later to not have your video on. If you need to ask a question or make a comment, please use the chat line, not hands up, and please don't do a conversation in the chat line because I can't pick out when somebody needs to ask a question. Okay, so if we start with membership of the board, which is agenda item 1, Jenny, have we any apologies as such?
Councillor Khan has sent her apologies.
All right, thank you. I do know because of a lot of meetings that she had today, Councillor Pattison wasn't sure whether she would make it or not, but she said her apologies in case, but she's hoping to be here. Minutes of the previous meeting, members, are we all happy that that's an accurate list of what occurred at the last meeting, and are there any matters arising? Diane, oh dear Diane, your surname is fooling me, or Steve's saying it, Diane McCaracha, name spelt wrong. Is that the correct spelling that you've put in there then, Steve?
Yes, it is. I think so, but she is on the call. So anyway, I just have to be perfect, you see.
Yeah,
okay.
It's 2 hours. Thank you. Sorry.
2 hours, right. Sorry about that. We will correct that. Yep. Interest, if any board member has interest, please ensure that you fill in the form attached to your pack and make sure that it goes to the governance officer as soon as possible, please. All the items on this agenda are to be held in public. There are no private items as such. So, deputations. Have we any deputations?
No, none received, Chair.
Right. I do realise that I haven't made sure that people know who is in attendance at this meeting because it's quite a large meeting. So, Phil, will you go through the list of attendees who are with us now, please?
Yeah. So, in addition to yourself, Councillor Kendrick, there's Richard Parry from Kirklees Council, Rachel Spencer-Henschel from Kirklees Council, Jackie Gedman from Kirklees Council, Mel Meggs from the Council, Dr Steve Ollerton from Greater Huddersfield CCG, Carol McKenna from Greater Huddersfield and North Kirklees CCG, Jane Close from Locala, Diane McCarricker from Locala, Matt England from Mid Yorkshire Hospitals Trust, Tim Breeden from South West Yorkshire Foundation Trust, Catherine Riley from Calderdale Huddersfield Foundation Trust, and Councillor Zaman from the Council's Scrutiny.
I can also see Councillor Pinnock.
As Councillor Pinnock's. Apologies. Yeah.
Welcome, everybody. Thank you for that.
Sorry, I also missed Helen Hunter from Healthwatch.
Oh, yes, I'm going to say I've seen Helen too. Have we any questions, Jenny, for item
None
6?
Received. No, haven't received any, Chair. Yeah.
Okay, so we'll move then to item 7, which is Kirklees' wide approach to inequalities. And I think Emily Parry-Harris and Owen Richardson are going to help us with this, please.
Councillor Kendrick, is it okay if I kick this off? Because I think we're going to do a bit of a triple act. So I'm going to start with a few slides and then I'll bring Emily and Owen in at the key points, if that's okay. So we've got a presentation to run through. So Olivia, will you be able to get that on the screen for me? Okay, so obviously inequalities has been a priority for us for a long time, and I think that as we've discussed in the previous meeting to this one, what COVID has done is bring that into sharp relief in terms of the focus that we need to put on this going forward. First slide, please, Olivia. So we're going to just take you through today what our commitment is, a proposal for the board to sign up to, what the intelligence is telling us for Kirklees, how are we going to approach this and what action we need to take. Next slide, please. So we have our Kirklees Health and Wellbeing Plan, which supports our joint health and wellbeing strategy, and we've got our economic strategy. And we've tied those together really well from actually the time that public health moved into the local authority. But actually, this is about how we can ensure that we create a strong economy by influencing and improving people's health and well-being. But actually, how do we do that in a way that is really mindful of the inequalities that people in our district experience? And how can we be really targeted in trying to tackle these inequalities? Next slide, please. So I really loved this quote, and I think it's really important. And we've just been in our Partnership Gold meeting now, ironically, but the quote here is from Michael Crowther, who is a Gold member, and he is the Chief Executive of Kirkwood Hospice. And he said, "We've been working towards a common purpose and worked in our fat silos far less. The pandemic was the urgent issue that has forced that. The common purpose was the catalyst, and thinking about the future of the partnership, we need a similar urgent issue or common purpose to galvanise us to continue to work as one and not in our silos. The inequality that we all recognise in our community and system should be the urgent issue, the common purpose that binds the partnership and motivates us to act as one." I thought this was hugely powerful, and I think it's really important to reflect that actually the commitment is not just from a health and wellbeing perspective, but it is actually over the entire partnership that Kirklees has. Next slide. So I think last time when we had the Health and Wellbeing Board, we did quite a bit on what the Public Health England report talked about in terms of the impact of COVID on inequality. I think it's probably worth remembering that actually the Marmot review, which was 10 years ago, and the subsequent 10 years on that was published in the beginning of this year, actually shows that we've actually deteriorated health, and we've had more greater health inequalities over those past 10 years. And a lot of that has been largely unnecessary, and other countries are doing better than us. So there's been worrying trends in terms of how inequalities have got worse, not better. Sorry, distracting. So a lot of that is related to social and economic conditions. So actually, this is key in terms of how we link those two strategies together and not look at this as just a healthcare or a healthcare system problem, and how we link that to the broader economy and the social determinants of health. Next slide, please. So I'm going to pass over to Owen, who is our brilliant public health intelligence specialist, who's going to talk you through what the local picture is.
Thanks, Rachel. Yep, my name's Owen Richardson. I'm the intelligence lead for public health at the council. So I'm just going to run through a few slides showing some of the data. I came to the Health and Wellbeing Board around this time last year and brought a whole load of data around health inequalities related to place, deprivation, gender, age, ethnicity. And we've also been updating our Kirklees Joint Strategic Assessment, highlighting inequalities around all those factors, plus disability, sexual orientation, and other things. There's lots of evidence that these inequalities exist in Kirklees. I'm not going to take up any time today going back over the data that I've shown in the past, but just very briefly, life expectancy at birth is shown here. We're now seeing a difference in life expectancy of 9 years for males and 7 years for females between the most and least deprived deciles. I've included some hospital admission data, so coronary heart disease and COPD. We see a strong social gradient there between the least and most deprived wards in Kirklees. And moving away from health-related data, looking at ethnicity by occupation or by tenancy, we can see some really strong differences. Next slide, please. This slide shows the differences in income deprivation by ward across Kirklees. So from Dewsbury West, which is the highest rate of income deprivation, over 20% of the population in that ward being income deprived, through to Kirkburton, which is down at around 5% of its population. Next slide, please. I think Rachel's mentioned the PHE disparities report, which was commissioned by the government fairly early on during the coronavirus pandemic, and was published in June of this year. Just some key points to bring out from there. They found the highest risk and worst outcomes from COVID-19 were for older people, males, those living in more deprived areas, and Black and Asian and minority ethnicities. Also, where you're born made a difference, and certain occupations, particularly caring occupations and those who drive passengers in vehicles, and whether you've got pre-existing comorbidities is a risk factor as well. Next slide, please. Just to highlight some of the data from that PHE report, this slide shows at the top we've got mortality rates by deprivation decile. On the left we've got males, and on the right we've got females. So for each decile there's two bars. The top bar is the age standardized mortality rate that we would expect to see. That's a 5-year average, and then the bar underneath is this year's mortality rate for the same period. And that's separated by non-COVID and COVID deaths. You can see a strong gradient between most and least deprived across the COVID and non-COVID deaths, excess deaths this year for males and females. The two charts at the bottom show some diagnosis rates by ethnicity and split by male, female, and also mortality rates split male, female, and ethnicity. So as well as the ethnic differences, we're also seeing some differences by gender and ethnicity. So something to bear in mind there. Next slide, please. Some data from the Office for National Statistics. So similar splits here for deaths, mortality rates, split by male, female, and ethnicity, but also split by age. So the top chart is aged 9 to 64, and just to highlight, males of Black ethnic background had a rate of death 4.7 times higher than those of white ethnic background. And then the bottom chart is age 65 plus, and I've just highlighted here females of Black ethnic background had a rate of death 2.1 times higher than that of white females. So some larger differences highlighted there in the data. Next slide, please. A slightly different way of looking at the same data. So this is risk of death, again by ONS. This time it's age adjusted, and it's also the second bar is fully adjusted. So that takes account of other factors such as geography, population density, deprivation, household type, occupational exposure. Even taking into account those factors, we're still seeing much higher rates in certain ethnic groups. Next slide, please. As well as the disparities report, PHE followed that up with a second report which summarised some of those inequalities, and they're just 4 points to pick out from that report. The long-standing inequalities that we're all aware of have been exacerbated by COVID-19. There's an increased risk of exposure to and acquisition of COVID-19 for ethnic minority groups, and increased risk of complications and death. And this is potentially driven in part by racism, discrimination, stigma, fear, and trust, or lack of. Next slide, please. Just very briefly to look at deaths by occupation. This is for males, and we can see clearly that certain types of occupation are attributed to higher risk, so such as caring, leisure, and other service occupations. And at the bottom, there's a breakdown of certain types of driving jobs, so taxi or cab driver, through to large goods vehicle drivers, all with increased risk of death through COVID-19. Next slide, please. And here's the equivalent slide for women. Again, caring occupations particularly high. I've pulled out the differences there at the bottom between care workers and health workers. Next slide, please. And this is the final one from me, just bringing us right up to date. This is some very recent data that we've had on COVID-19 cases in Kirklees. And this is a chart showing the proportion of cases by deprivation quintile for weeks 22 to 27. So that brings us up to early July. And we can clearly see that the vast majority of our recent cases have been in the most deprived quintiles. And we're also seeing, if we look at other data, we're also seeing an increased number of cases in our Black, Asian and minority ethnicity populations in recent weeks. Next slide, please. That's it from me. So I'm handing over now to Emily.
Before you do, and I'm just asking your opinion. I know Dr. Ollerton has a question, and I assume it came up partway through your presentation. Do you want to take a question now or wait until you're completely at the end?
I don't mind either way.
Okay. Steve, do you want to ask your question now?
Yeah, please. Owen, fascinating stuff. Thank you so much for that. I just, can you easily go back to slide 9 or not? Oh, you can. That's good. Just tell me what those top bars meant again. So if you take either the right or the left, I don't mind. What was the top bar compared to the bar below it?
So the top bar is the average over the 5 years, 2014 to 2018, the average mortality rate.
Right, sorry, got that, right. Okay, so I got that. If you could just go to the next slide then. So is this, are Black and ethnic people catching it more or just dying more? What's this saying to us here?
That particular chart is specifically around deaths. I think did the previous one have diagnosis rates as well? Sorry, could we go back a slide, please? Yeah, so the bottom left-hand one looks at diagnosis rates.
So, right, so it's actually a bit of, they're catching it more, but actually even more are dying from it, aren't they?
It's both and, Steve.
Yes, got you, that's fine. Sorry, do you mind if I carry on? Slide 15, please. This is another fascinating slide, I thought, with the quintile. Yeah, the quintile. Why has that changed? Why in the early stages was it, well, reasonably well distributed? Not very well, but 34% in your first quintile. Why has that changed in the last 5 weeks? What's different?
I think even in the, sorry, does Emily want to come in or Rachel?
Rachel's put her hand up, so let Rachel go first.
I think the complexity about this is quite small numbers, but equally it will be about the sorts of testing that we're doing. So obviously we've managed a number of outbreaks in workplaces where we've been testing the whole population, and some of those workplaces are probably the more routine manual type workplaces. So don't forget, this is all kind of dependent on how and who we are testing in order to give us those figures. So that will account for some of that difference, Steve.
Okay, all right, thank you. So just a final point to make. When I was seeing your what's it called, jobs, the job slide, as it were, it's quite clear that jobs where you come into close contact with people puts you at greater risk, and this just highlights how either social distancing or wearing face coverings is so important, isn't it? Because that clearly shows if you're in a job where you're in close proximity to people, be that in a car or in a caring role, you're so much more likely to either transmit or catch the virus, aren't you? I mean, it's really quite stark. And those people who can have jobs where they don't have to meet up with people very often are staying safe. It's quite stark. That's it from me, thanks.
Emily, did you want to add something to that, or?
No, I'll carry on. I think some of what Steve was just saying is absolutely clearly correct. The most important things that we have in our kind of toolbox for dealing with COVID continue to be regularly washing your hands for 20 seconds or more, soap and warm water. If soap and warm water isn't available, then alcohol hand gel as a good second, but soap and water is preferable. Social distancing remains absolutely key. If people are symptomatic in any way, then they must get tested, and they must have a good idea of who they have been in contact with over the period of time that precedes their illness, so that we can undertake test and trace and use of face coverings. Absolutely, those messages remain the same as they ever were at the beginning of this.
Yeah, very good point.
Yeah. Okay, sorry to have disrupted this presentation, but I knew Steve was talking about some of the detail on the slides, and we'd lose it if we went way past. My apologies. Do you want to carry on, Emily?
Yeah. Okay. So thank you for having us. I think I know most of you. I'm Emily Parry-Harries. I'm consultant in public health. So I'm now going to take us into kind of so what are we going to do? We've had the data presented to us, and Rachel set it in the context of we were already on a journey, and we were already spending time talking about inequalities. But what are we going to do now that moves us into action, now that things have been so starkly clarified for us? So there are a number of things that we need to be conscious of in terms of the broader impact of the pandemic. We have very, very rapidly moved to being able to deliver more services and support more outcomes in a very digital based way. I've spent the last 20 years working in various parts of the NHS where we have been trying to get online consultations up and running. We now suddenly can do that, and for part of our population that is brilliant. It's working incredibly well. There is a minority of our population, but a really important minority, who are digitally excluded. That is a very, very real issue for us at the moment. Particularly concerned around the mental health impact, not just of young people, but thinking of young people specifically. This is a very, very difficult time to be doing your GCSEs, to be doing your A-levels, to be making those decisions about your future life, your career, your aspirations. The kind of the flip side of that same coin, the underlying health conditions for older people, huge concerns around loneliness and social isolation. We need to move into a space where we are physically distant from each other, but that people are able to maintain a level of interaction. Clearly very worried about a disproportionate impact on disabled people, although for some disabled people are actually reporting that because of the move to digital platforms and some of the work that we've done to make sure that people are included, actually they're having a better experience of access to services, but we just need to keep some of these groups particularly in mind. And then there's some emerging evidence around the LGBT plus community and needing to be more specific and targeted with our messages. I think that's true of a number of communities. I've just said that the key messages of hand washing, social distancing, they remain and they have been the same since the beginning of this pandemic. That is at a population level. I think we have been fairly successful at giving those messages. What is becoming increasingly clear is that there are certain sections of our society where we're not getting those messages through. So we need to become much more targeted and much more subtly nuanced in how we put those messages across. Next slide, please, Olivia. Okay, so in terms of how we're going to do this then, community engagement is going to be key. Humility is going to be really important in this as well. Our communities know each other. There's some fascinating work going on with our communities team where they're starting to unpick some of the kind of urban myths that exist around COVID. So engagement and humility. Intelligence-led, the data is getting better. The data was not brilliant at the start of this pandemic. I do think while it feels like we've been doing this forever, we have to remind ourselves actually we've only been doing this for 14 weeks. So we are still very much learning as we go. The data is getting better, and that is allowing us to become more targeted. I think our communication is getting better as well. We are getting better inroads into our communities. We've had a number of GPs in the last week or so do a piece for camera, talking heads, so that we can start to get messages put into our communities that aren't just written, that they're oral as well, increasing the number of community languages that we're making those messages available in as well. And playing much more into that West Yorkshire piece as well. We're working rapidly now to get boots on the ground and increase the messaging that's reaching communities immediately, but also mindful that we are going to be in a space of living with COVID for some time to come. So working to that kind of longer time scale of autumn as well. And we are specifically trying to focus on 5 areas, because we are recognizing that this is touching all elements of people's lives. So we're talking about health, economy, education, housing and environment. Next slide, please. So this is a slide that members of the board will have seen before. What this does is takes us across the various things that cause inequalities in healthy life expectancy, and kind of talks to those 5 areas that I've just mentioned. I'm not going to go through it in huge detail, but Baroness Pinnock, you've asked if these slides will be made available. They will be made available after the board. So I'll leave that for people to look at in more detail. And if you've got issues, questions you want to raise, please get in touch. Next slide, please. Okay, so Rachel made some reference to the Marmot review, the 10 years on work that was published just at the start of lockdown. It's suffered by its timing, but equally we now need to go back to it and say, you know, this is a really good, solid piece of work. So I'm not going to go through all of these here, but I wanted the board to have access to them. So if we just skip this slide and the next one. And then, yep, so this slide then splits down the recommendations that Marmot makes into those 5 areas that I described earlier. Being very, very clear that in terms of health, we're talking about early intervention to prevent inequality, health inequalities happening in the first place. We're putting equity and well-being at the heart of what we do. I am really excited's not the right word, enthusiastic, full of hope, that's what I am, that we will now really start to see the impact on inequalities. If we then move on to think about the economy, we're looking at being very kind of specific in our communities, targeting that resource, our most deprived communities, looking at inclusive growth. Education, we're talking about equity being at the heart of all of our decisions. We need to increase attainment in our poorest and most deprived populations fastest first. In public health, we often talk about a concept of, oh God, my brain's gone dead. Rachel, what's it called? Where we do something for everybody, but we do more in our more targeted populations. Progressive universalism, that's what it's called. Oh dear, it's been a very long few months. So we're taking a very kind of progressive universal approach here. We are doing something for everybody, but we are very, very clearly saying we are going to do more in the communities that need more. And then lastly, on housing, there are some specific commitments that we are making. Thank you, Phil has put proportionate universalism in the typing. Thank you, I'm sorry, that was a brain moment on my part. And then, so that the housing point, lastly, we recognise that how and where you live your life, the housing that you have available to you is absolutely vital in terms of you living well. Next slide, please. So that's just to reiterate those 5 areas. Very clearly, there are some specific issues we need to be picking up with the BAME population, and Owen made reference to the work that Kevin Fenton has been doing, and Steve, you picked up your point about, is it that people from BAME backgrounds are getting COVID more, or whether they are dying from it more. it is both and. There is something about occupational exposure, but there is also something about the management of long-term conditions that tend to be more prevalent in our BAME populations. So we need to tackle that from both ends. There is some specific work that we're doing around economic recovery, the Healthy Holidays programme. Clearly, the impact that this has had on families, particularly those living in deprivation and eligible for free school meals, is huge. So we're picking things up to kind of wrap around families over the course of the summer holiday. A huge opportunity for investment in cycling and walking, and you'll see lots of work happening around that over the next couple of months. And I'm really proud of the work that we did around the emergency accommodation for rough sleepers right at the beginning of this crisis. Everybody who was in a position where they'd been sleeping rough were housed. And that has been relatively successful. There've been a couple of individuals where that's been more tricky, but I'm really proud of that work. And then last slide, please. Okay, so the next steps then is to take this work through the Integrated Health and Care Leadership Board. We want a virtual network of inclusion and diversity champions in our key anchor organisations. So I would ask you as board members to have a think about who those people can and should be from your organisations. And then to leave you with some questions and to ask you to reflect on what are the absolute must-do things that we now have to do as a partnership, and where should we be focusing. I appreciate that's been a real whistle-stop tour, but I'm very conscious of time. I'm happy to take any questions.
Helen Hunter has put a question in the chat line.
Okay, let me just expand that question so I can see all of it. Do we have any stories?
That's okay. I just asked about, I'm really aware that there are some people who will have a better life post-COVID, and that some of those people might be people who were homeless, who now have might have some sort of far better living arrangement. So I just wondered if we had any of those types of stories.
There are, we're asking for some case studies to be developed specifically for that. I think those very kind of personal stories are incredibly important. We've also got some fabulous stories of how not just local authority, but Kirklees staff generally have really stepped up, gone the extra mile, thought imaginatively, and we've got to really capture that spirit. We need to keep that going.
Can I just ask, and I know Kath has got a question too, but can I just ask, attached to the homelessness issue, we thought of it as one cohort of people that we housed, and it was, you're right, brilliantly successful. But I've come across cases where relationships have broken down and suddenly someone hasn't got a home that they thought they had. Is this an ongoing thing that we're managing to deal with, is my question.
I think so. I'm not close enough to the specific services, but what I'm hearing from those services that they are able to respond much more flexibly and much more rapidly than they had been previously. And I think that is a really clear example of where, if you think back to the beginning of this presentation when Rachel gave you the quote from Michael Crowther, we've been able to be in a space of responding more flexibly and more imaginatively, and we must keep that.
Yeah. Councillor Pinnock has a question about who are the members of the Integrated Health and Care Leadership Board.
I think, Phil, is your comment an answer to that question?
Oh, you've put...
Yeah, I've just put something in the chat. The list of people is not the names of the individuals, but the roles is in the agenda pack under the terms of reference for the board, page 45.
Oh, it's not on my page 45.
Oh, sorry, it's page 39. I was looking.
Oh yes.
It's that difference between the numbers of the PDF document and the
yeah
numbering thing. Yeah.
Okay.
Can I raise something then?
Yeah, sure.
Yeah, because unless I turn over and there's a few more, is what then concerns me. I mean, I think that's a great presentation. obviously the thrust of what you're going to do is the right one. What was that phrase? Progressive something or other? Universalism.
Proportionate universalism. I'm going to write it down so I can't ever forget it again. What a thing to forget.
Thing, actually. Oh, but anyway, there we go. So that is right. Just, and Viv will understand what I'm going to say.
I know what you're going to say.
You know what I'm going to say, don't you?
Yeah.
There needs to be in there somebody with a political outlook, because how do I put this? We need to tell a story that shows that by improving the health and inequalities of those most deprived, whose inequalities are the worst from the norms, we help everybody. Because unless we tell that story, and Kirklees in the past has not been very good at telling that story, very good at focusing on the most deprived. Well, I've tried very hard to focus on the most deprived, but unless you tell the story that by helping the most deprived, everybody benefits, we will have some political backwash to deal with. I don't know what you think, Viv, about that.
I knew that's what you were going to say, and it did occur to me, but there's a bit about that board reports to this board, so there is a political oversight as to whether it needs a politician on that board. I'm open to other views as such.
Could I come in on that?
Yeah, sure.
So I think this is the board that sets the Health and Wellbeing Board. I think is the board that sets the strategy and the framework, sets the priorities, and the other board is effectively the board that is the doing group and is tasked to, across that set of organisations and services, deliver against the strategy and priorities set by the Health and Wellbeing Board. And therefore, I think this is the Health and Wellbeing Board will be the board that picks up some of the things that have been said about the tone, the messaging, and we will need to, when we operationalise that, pick that up. I think that's just the other way into some of this is we increasingly think about place-based working, and how we're working both at taking that in both a geographically localized context, but also in the way in which we are working with people. That gives us the opportunity to tell that story because it becomes a much more nuanced and localized story.
Right. I mean, I can see both sides of it. I suppose from a politician's point of view, it's the timeliness of the information. Boards happen very periodically, and I think with greater timeliness, even Kath Pinnock would be happy.
Nay. Yeah. Can I come back?
Yeah,
I
sure.
think this will be important because we've already seen, or I've heard anyway, signs of this sort of, and what about us? You're missing out us, even with a ethnicity undertone to it, or even overtone to it.
Yeah.
And I think we have to tread carefully but firmly in the right direction. And all I'm saying is let's tell the story that by helping everybody, by helping the most deprived, everybody benefits. And I'm not sure we tell that story. That's all I'm going to say. I've said it twice now, but I do think it's important.
And I agree with you, and I think we have to think about how that's managed. Whether it's membership of that board or not, I'm not sure, but we can come back to that as such.
I see the board is now, a subset and all the rest of it. That's fine. Yeah. It's where somebody has an input into it is important.
Yeah. Okay, can we have a think about that, folks, and come back with an answer? I notice people are putting full questions in the chat line. If you have a question or a comment, you only need to say speak. But Catherine Riley, do you want to make your point, please?
Yeah, sure. Hi, everybody. So a really interesting report, and I've been chatting to colleagues about Black Lives Matter over recent weeks, and one of the conversations that I have with some of my BAME colleagues is about where do we start? How do we start to do things differently? And one of the things they talk to me about is inclusion and representation and our awareness of that. And so that's what that question is, and that we could even start with ourselves about representation, because if we're talking about dealing with inequalities, that feels like a good place to start. So how do we know, for example, with this report, what the people it's written about think about it? The people who it most points to, what do they think about it? Because as I look at the screen now, everybody's white.
Yeah, fair comment. Jackie, do you want to speak? Are you frozen, Jackie Gebman? I think you might be. Oh well, we'll carry on until Jackie's link's unfrozen as such. Can I just go back to, and I think it's part of what Emily was talking about, when you talked about some GPs, Emily, who'd done these talking head, I assume, videos. Is that information also going out on things like community radio and so on? Because, we're saying on one hand, people, we can hear you now, you froze and we couldn't hear anything. I think you're on mute, Jackie.
Oh, am I? Sorry.
Oh, it's showing as mute, but
am
I can
I
hear
back
you.
now? Have you lost me?
You are.
Oh, okay.
Sorry,
okay.
you just froze as such. Okay, we'll come back, Emily. Go on, Jackie. You wanted to come in there.
I think it was just to come back on the point that was made previously around inequality. I think the council is doing quite a piece of work around looking at how do we move from always having a focus on inequality to actually really making rapid progress. So we're just doing a piece of work which picks up a number of the issues around, what's our response, what's the political oversight of that, how do we prioritise? And I just wonder whether it would be worth bringing that back while it's still an early thoughts paper to the Health and Wellbeing Board to help that get that shaped, so that kind of what comes back in its entirety covers some of the concerns that both you and Councillor Pinnock have had.
Okay, thank you for that. Thank you. Emily, going back to this talking heads, I was just asking, what was that information also just done as an audio thing so it can be used on community radio? Because we talked at one point about people being digitally excluded. Well, having just videos that are on digital systems doesn't help them, does it? So
No,
is that information going into community radios, into the mosque, because the mosques all have mosque radio as well?
They do, yeah. So talking heads is just comm speak for when somebody speaks to a camera and it's just them talking. I'm learning lots of things at the moment. So yeah, those talking heads have been recorded. Those audio files will then be available and can be used in a number of different settings. Part of that will be about making it available to local radio stations, but the audio files can also be made available and played in the mosques. I think that one of the really important things is getting a range of different voices who are giving not the same message, because we need to give the same information but in different ways so that it appeals to different elements of our society. So I've been talking to children's services this afternoon about finding a couple of really confident looked after children to do some talking heads pieces for us, finding some imams to do the same, so that we've got a range of different people giving the same information but in different ways that appeal to different elements of our society.
That's great. Thank you.
I'm
for
too
that.
old to talk about young people's things now, apparently.
Oh, how cruel.
I know, harsh.
I mean, I have one last point. I'm looking to see if anybody else has got a question or a comment. I can't see anybody else. I'm sorry if I'm missing you. You mentioned about the free school meals and how important that continuation, and I've been really pleased about the increased number. I think it was more than 1,000 of increased claims. Have we reached the deadline that people need to have put a claim in? Because
I don't think so. I think the deadline for the claim is the 31st of July.
Yeah, so for me, for every board member and particularly every councillor should be making sure people in their communities know that it's worth making a claim, with people who are always not going to qualify for free school meals, and their employment situation has changed so much that they would now. And I beg people to make a claim, because it is so important to help families in that case.
It is. Let me check the date for you. If it's not the 31st of July, I will correct myself and let you know. If I'm right, I'll leave it at that.
Lovely, thank you. Can I just say thank you to Rachel, Owen and Emily for an excellent presentation. And as has been confirmed, we will be getting a copy of the presentation, which will be excellent to have. Thank you so much. Thank you. Can we move on to item 8 then, please, which is the Kirklees outbreak control plan. And I think, oh dear, I'm using two different computers and 2 mice, and I'm getting the wrong ones.
Councillor Kendrick, can I help here? Because Jane was going to present it, Jane O'Donnell, but she's been called away to something urgent, so I've said I'm happy to cover it for her, if that's all right.
Yeah, that's absolutely fine. Thank you.
Okay, so members have obviously had the paper in terms of both the plan and the paper to support it. I will just point out that whenever Jenny downloaded this and printed and put it in the papers, it's probably now been updated since, because it's very much a live document that we're keeping on our public-facing website, so that it gives confidence that we've got a plan in terms of how we're managing outbreaks. We were asked to publish this by the end of June, which we did, and the plan covers 7 key themes that you can see in the paper, which is how we plan to manage local outbreaks in things like care homes and schools. How do we manage high-risk workplaces and other communities and other locations to ensure that we can manage outbreaks within those settings, and actually being quite preventative as well, not just reactive in those. Using mobile testing units and other testing options to try and manage and reduce infections. Doing some local contact tracing, connecting into the NHS test and trace system. How we manage data in terms of making sure we're on the front foot with understanding our local picture of infection transmission. How we support our most vulnerable people when they need to self-isolate. So how can we do that, building on the huge success we had with our community response during COVID? And how do we have governance structures that gives assurance? So you'll be aware that we've had a Kirklees Health Protection Board that is a subcommittee of this board, and we report to you every 6 months on the general health protection of the Kirklees population. We've also got a member-led outbreak board, which is cross-party, where they oversee the delivery of the communication plan that supports our outbreak control plan. So what I'm asking today is that you note the context of the report, and that you please approve the plan and its associated governance. Happy to take questions.
Thank you. I think Councillor Pinnock.
Sorry, Chair. Just to ask you, I mean, that's all perfectly reasonable, and well done, Rachel, for all you've done with the 3 outbreaks now. Yeah, it's been really, really well done, all, you know, right from the beginning. The data. So the national data, my understanding is you get the first half of the postcode, but not the very detailed stuff. Is that right?
No, we get the full postcode.
Oh, right, the full postcode. Okay, okay. So you've got it down to sort of 20 houses sort of level. Right, that's good, because that certainly wasn't the case originally, was it?
Okay. Any questions or comments, colleagues, on the plan as such? No? Okay. I think we're asked to note the contents of this report and the plan, and to really indicate that they were happy with the plan. Helen Hunter, you want to ask something?
It's a comment, and to me it looks incredibly comprehensive, does the plan, and perhaps it's my work perspective. Is that sort of looking at the document, it made me think about what we were doing to and for our community rather than what we are doing with them, if that makes sense. So it was a lot about what information needs to be communicated to them, what needs to be provided, what needs to be delivered, and not necessarily with a focus on the kind of reciprocity that's needed in order for a plan like this to work, where we have sort of the buy-in of our public. So just something for me about how we get that engagement, and I was really interested to listen to what Emily was saying about the various different ways in which we're communicating and trying to access different populations. But it just struck me as a plan for what we were going to do as professionals, not a plan for what Kirklees was going to do as a place.
I'm happy to answer that, Councillor Kendrick. I think that's really helpful, Helen, because I think you've hit the nail on the head in terms of sometimes so we've published the plan, and I suppose it would never go into sort of the level of detail in terms of some of the very specific communities we might work with, or the specific targeted areas we would pick up on. Just to give you some reassurance, obviously our mantra is about how we work with and not do to. So the implementation of this plan will be done very much with that in mind. And we've got a multi-agency test and trace group that work on how we deliver this in more detail, and actually work with our local elected representatives to make sure that community voice is coming through. So it's absolutely not missing in terms of how we're doing it, but I do get your point about the plan, and I think sometimes when you've got those quite defined headings you have to follow, it does feel a little bit in the sort of doing tough sense, but just to give you some assurance that that's not what we're doing here.
Lovely.
I think Jackie wants to come in, Councillor Kendrick, if that's okay.
Oh, yeah. You're very
it was
welcome,
just,
Jackie.
Sorry, it was just to add to Rachel's point, Helen. I think that we recognise that, and I think these, as they always do, end up having a number of audiences. I think we're really clear that we have a community protection plan that's owned by the community, though, and we work on that collaboratively together. So I think this is just the level above the level of detail I think that we would have at a local level, which would be very much more restorative.
Mm-hmm. Did you say, Rachel, that this plan is published or is about to be published?
It was published in draft form at the end of June. So obviously, if the board with the board's approval, it will become a non-draft document, although accepting it's a live document, so will be regularly updated.
Yeah. It's just I am aware, and I should stop looking at social media, but there's, beside a lot of unpleasant stuff, there is some genuine anxiety in communities coming up with all sorts of cunning ideas that the council ought to be doing. And actually, if they looked at this plan, they could be reassured that the council actually is doing that. So for me, I'm really interested about when it's published and where the link is, because I think people are not because they can't see things happening, they don't think things are happening, and you folks are working so hard to achieve so much. It's rather sad. So I'll try again now, unless somebody else has got no more questions as such. So the Health and Wellbeing Board members is asked to approve the Kirklees Outbreak Control Plan and the associated governance of that. I'm assuming, unless somebody protests at me now, that we're happy to approve that. Yes? Yes? Fine, thank you. We move on to item 9 then, please, which is progress on the establishment of the Integrated Health and Care Leadership Board, and I think Steve Brennan is going to take us through this. Steve.
Hiya, thank you very much. Can everybody hear me okay?
Yep, we can.
Good stuff. Okay, I'll just do a really brief introduction to this. There's a short paper in your agenda pack, and I'll just kind of highlight a few things from that, if that's all right. So I think we, seems like a long time ago now, but I think we gave an update to the Health and Wellbeing Board in an informal session about the peer review that's mentioned in the paper. One of the recommendations of that peer review was that we bring together the Integrated Provider Board and Commissioning Boards, and the paper sets out how we've gone about doing that. There's been a bit of a delay in doing some of this, partly due to COVID, but the first meeting of the board took place in July. Initially, it's going to have a key role to play in helping oversee the stabilisation and reset work, and I think the next agenda item is going to go through that in a bit more detail. Some of the engagement work we did leading up to the establishment of this new board confirmed that there was a desire to use it as a way of doing the new integrated delivery plan that will help us achieve the health and wellbeing plan. There's a copy of the terms of reference included in the papers as well for information, and they're very much drawn on the existing terms of reference of the Integrated Commissioning Board and Integrated Provider Board. And going forward, this new board will meet on a monthly basis, and the next one is the first week in August. So I didn't really want to say much more than that, but I'm more than happy to answer any questions or take any comments that people have got.
Any questions, colleagues? Not seeing any coming up as such. I'll make a comment in terms of I absolutely welcome the establishment of this board. I think it's absolutely vital to the progress we need to make. And we're asked to note the contents of this paper. I think that's it. So thank you very much, Steve. For
no worries.
That.
Thank you.
Okay. Cheers.
Brilliant. Thank you very much. Bye-bye.
Bye. So item 10 is the stabilisation and reset across the Kirklees health and social care system. And I think we have, hopefully, Natalie Ackroyd and Vicky Dutchburn here to take us through this item.
You do. Thank you very much.
Fantastic.
So my name's Natalie Ackroyd. I'm the Senior Strategic Planning, Performance and Business Intelligence Manager for Greater Huddersfield and North Kirklees CCGs. The slides have been circulated with your meeting papers. We're not planning on going through each and every one of the slides. We take it that they've all been reviewed before the meeting. However, we just want to give a little bit of an overview and an introduction to some of them. So I'm going to start, and then I think Vicky will come in and add some more context. So just in terms of looking backwards, we did submit our 5-year finance and activity plans back in December, which were at an integrated care level at West Yorkshire and Harrogate. And we have had an opportunity to refresh our 2020-2021 plans and agree what the investment was before the level 4 incident was declared. At that point, there was a message out that all non-urgent and elective work was to be stood down, and the focus was very much on critical care and building capacity, which was to respond to the COVID crisis. within the pack, there is the priorities during COVID and the phasing of those. So phase 1 was very much around supporting the increase in that critical care capacity and very much around the safe and effective discharge of our patients and supporting the vulnerable shielded patients. Phase 2 was still very much about supporting those patients and understanding what the wider impact on the different populations that we expected COVID to impact on. But the real effort in phase 2 was around coordinating and resetting to a new normal that we now refer to and call the stabilisation and reset process. That links us now to our current phase 3 model. And the ICS developed a 6-step framework with key questions for each place to consider. Essentially, those questions were around what the priorities were for our population, what the interdependencies are with other providers and services within Kirklees. Really importantly, in terms of what we felt our constraints were and are and will continue to be as we continue to work with and post-COVID. And also what innovations we wanted to retain. We've been working differently over the last few months and we've done some really good things. So what do we want to continue to do and retain? I think I'm going to hand over. I think Vicky's got a few things to say around our local response.
Yeah, so as Natalie said, that was the start of the reset phase. And one of the things that we did at that time when we did our initial plan as a system is when we submitted it, we had to do a presentation to the whole of the region in a World Cafe style. So in doing that, we were only given a 10-minute slot, and obviously as a Kirklees system, we had a lot more information to share than we could pass on at that point. But we did a summarised version on the 28th of May for the ICS, so that they could understand where we were in Kirklees and what our next steps were going to be. And in your pack, one of the slides, I think it's possibly slide 6, but I don't know what page it will be, just shows you the breadth of the partnership and the people who were involved in pulling that work together for us. What we then did is after that event, we agreed that we would do a Kirklees version of the World Cafe style, so that it gave all our partners across the system a full opportunity to share their experience of working through COVID, what had worked well, what they wanted to retain, what they would probably not do again if they had the opportunity, but also what we needed to be really cognizant of as we started stepping services back up for our population and what the impact would be given some of the restraints that we had. And in doing that, we were able to identify a number of priorities across our system to do some pieces of work. What COVID has done is, which sounds really strange, but it gave us an opportunity as a system to think about what we wanted it to look like going forward in the future. And it's how we use that to maximise our developments going forward, but also build on what we've learned through COVID, and especially around the pace of change that we've managed to do things in this time. I think we all reflected that sometimes we get tied up in some of the governance structures that are in place and the bureaucracy, and actually we've proved that we can do things very fast and very safely. Because they're the right thing to do. And what we did do in the pack is we shared just a couple of examples of some of the things that we've managed to do collectively, which includes some of the setting up of the satellite testing sites across Kirklees, that we've managed to procure new services such as mental health crisis lines for both staff and for our public. So we mobilised the volunteers to be able to support our local communities. So there were lots of things that we wanted to specifically pick up on there. What we also identified were the emerging themes that we want to make sure we work on as priority areas going forward across the system. And in the pack, we've included a slide that just draws out some of those key themes that we had, and I'll just touch on a couple of them. Mental health I've already talked about, and that's not just the mental health of known patients, but it's the mental health of our whole populations, the impact of living with COVID has had on them for a whole range of different reasons. And everybody has had different resilience and being able to deal with that in different ways. So we need to make sure that we can make our communities resilient, put models of self-care in place, and also maximise the services that we've got. There was a strong feeling about ongoing communication, that one of the real positives through COVID has obviously been how we pulled together as a whole system and have worked together, but also communicated in a consistent way. And there's something about that we really want to keep working on and keep for our futures, so that we can have single versions of the truth, and that we're doing it as a system, as we've said. Another key point was obviously about the digital agenda, because one of the things that we've been able to maximise during this period is the digital agenda, using video consultations for GPs, which is something we'd been trying to work on for years, and had been very slow, but has suddenly taken off at a great pace. And there's the strengthening of this voluntary sex community. And one of the things that was really interesting was the discussion that we had around the role of care homes. So there's lots of work gone on with care homes, lots of support from all partners have gone into care homes to help them look after the population that they already had, but how their efforts have been able to support the wider system, so people not being admitted to hospital if we could maintain them where they were living. And the discussion that we had there was about seeing the care homes as an equal partner in future developments, because their role is crucial to how we want to develop our community services. So in doing all of that, we're making sure that people know what we've been doing, and we're having various discussions across the whole of the system, both local and at an ICS level, and sharing some of the learning. But some of the next steps that we've identified for us as Kirklees is that redoing our reset plan has fallen on health as a leader, as a lead organisation for this. But we want this whole work to be an integral part of all the planning that we're doing across Kirklees. So to make sure that it's a key component of the refresh of the Kirklees Health and Wellbeing strategy and the implementation plan that was mentioned earlier. And to do that, we're looking at setting up some smaller working groups around the key areas that we've identified, so that we can further build on those, agree what the actual action priorities are, and so that we can start taking those forward. And just before I close and take it to questions and any further discussion, is just to make people aware that obviously the government and NHS England are going to be releasing some new planning guidance for CCGs around the activity in hospitals and what potential budgets might look like going forward. And we are expecting that sort of mid-July. So obviously all of that will play into any work that we do, though so far it's been pushed back, I think, on 2 occasions already, so we'll see if it arrives. And that's all I wanted to say, really, and open it to questions.
Questions, anybody? If you could indicate speak in the chat column, I'll bring you in. Nothing so far. We're asked as a board, there's 2 things. I'll do the second one first. For any comments on the emerging themes, which was, it's page 57 in your papers. Anybody, any thoughts or comments on that? I mean, I'm not thinking of anything different from what's listed here, but no. Okay. It doesn't look, Vicky, like you're getting any questions as such.
That's fine.
So the board is asked to endorse the approach being taken to stabilisation and resetting Kirklees. The board happy with that, and we appear to be agreeing with the emerging themes that you've identified. So if we record that as a decision, thank you so much for your presentation, both of you, and for your time. Thank you.
Thank you.
So if we move on to item 11, which is the learning and evaluation shaping the future of public services in Kirklees. And this is a verbal update from Rachel.
Yes, thank you, Chair. Me again. So it was just really to kind of share with the board some thoughts we're having in terms of how we can learn from what's happened during COVID and try and do that as a system rather than just as an individual organisation. So the proposal is to ensure that we have robust and consistent approach to evaluation, which builds on our existing knowledge and activities and helps us to be clear about what we need to do to improve our 7 shared Kirklees outcome. So we're proposing to commission some activity that will help to understand the direct and indirect impact of COVID-19 on our communities, our businesses and our partners. Assess our response at an organisation, system and population level to see if there are improvements we need to make to work as a partnership, how we can gather learning and evidence from before, during and after. I say after with a slight trepidation because I don't know when that's going to be, but certainly as we move through the different phases of COVID, to identify the opportunities to transform what we do and how we work. And that will be a mixture of qualitative and quantitative intelligence gathering. And then hopefully what we can do then is create a framework in which we will understand what we need to be doing differently and measure that so that we're being a little bit more intelligence-led, which is something that we've always wanted to do. So the council has already said it's comfortable to support this approach. So I'm raising it here just to get views from the Health and Wellbeing Board as key stakeholders in terms of, let's put some intense effort in this so that we can genuinely gain something positive about what we've gone through. That's it, Councillor Kendrick.
Thank you. Thank you. So, colleagues from across the board, have you comments or views on what Rachel's described? No. I mean, the thing I am aware is that each organisation and service, etc., is identifying things that they've learnt. And Vicky was talking about some things that have started that they want to take forward, and it is that building it together, isn't it, rather than each organisation and service doing it separately. Helen Hunter wants to mention something.
Hi.
Hi.
It's so I assume most people will be aware that Health Watch currently has an ongoing piece of engagement work where we're asking people about their experience of health and care services. We've had upwards of 300 responses so far from people living in Kirklees. Vast majority of that is about GPs and pharmacies, but we're getting some stuff about social care as well. It's a sort of an interesting, diverse picture that we're receiving, and obviously we're very happy to share any of that information. We've already processed some of that and provide that already. What we are also trying to do is map out any pieces of engagement work that we hear about, so that we actually know, because for us, it's so important that people's voices get heard at this time and that people are given the opportunity to choose how to air their views in the way that they want to. So we know lots of different organisations are asking for feedback, and we don't want to be kind of re-pestering people to get them to tell their story to us again. I'd rather that we pulled all of that information and that learning together based on what people told us in that first instance. So we're trying to map that out and make sure that we're kind of pulling that together somewhere. But that's just for your awareness, because I'd be really happy for us to be sharing all of that learning.
I feel that you're now going to become part of that project steering group, Helen. Thank you for that.
Yeah, you've just volunteered yourself, Helen, I'm absolutely sure, but I know you're up for it. Any other comments? No, I think what you've described, Rachel, it is the way forward, and we just hope that people have the energy, the capacity, and the time to do what actually is quite vital work. That'll be the challenge as much as anything. So thank you for that. So item 12 is pharmaceutical needs assessment update. These come to the board as a matter of course. They are for information. We've got change of ownership of 2 pharmacies, a new trading name for another, some supplementary hours changes, one to increase but one to decrease. I don't know, and that's in Cleckheaton. I don't know if that would be an issue there, Councillor Pinnock. And then the relocation of 3 pharmacies, none of them going very far from where they were originally located. So that's purely for information. I think we are at the end of this agenda. Could I remind everybody that the next meeting will be the 17th of September. The meetings start usually at 2 p.m, but that'll be confirmed in papers to you. If people could try, and I know where we've got crossover of meetings, it's difficult, but if you could try to join the meeting 10 or 15 minutes beforehand, that is an enormous help. But thank you to all the people who contributed today, and thank you all for attending. Thank you.